Okay, so I just want to kind of preface this. My older daughter, who's 5 years old, tested positive for COVID-19 yesterday. So we're still trying to figure out our situation. My husband's watching the older daughter downstairs, and I have the younger daughter upstairs. So you might see a little human being trying to be disruptive during the meeting, and I apologize in advance if that does occur. So these slides, I updated the data for COVID-19 as of last Thursday. I do want to disclose that I have some stock of Moderna, Antigen, Zomedica, and Northwest Biotherapeutics. And next slide, please. So the learning objectives for today are to discuss the current state of with the COVID-19 in terms of patient cases, presentation, and vaccinations as related to the Omicron variant. Describe who is eligible for treatment and prevention for COVID-19 in the outpatient setting, and differentiate which monoclonal antibodies are active against the Omicron variant. Next. So if you look at the number of cases for the Omicron variant, as of last week, the number of new cases were 748,484 on a daily basis, and with that 7-day average of 740. So if you kind of think back to what was occurring on this timeline, this December, so between July and maybe February of last year, we were dealing with what we would call the beta variant. And then once we started to hit about July, maybe into October-ish, we were dealing with the Delta variant. And now we're starting to see the Omicron variant as the beginning of December. And one of my pharmacy residents, Sophia, texted me, and she's been a student with me on 3 rotations, and she said, Dr. Ramanathan, we're flattening the curve vertically. And so the number of cases are going up, and that kind of has to do with the R0 related to COVID-19. Next slide. So this comes to us from our world in data in terms of the COVID-19 deaths, and it compares various first world countries, I would say. So Italy, United States, United Kingdom, France, Canada, Germany, and Japan. And the United States is the purple that you see here on this graph. And so with this, I would have to say, maybe we're not quite there as much as maybe with the beta variant in terms of the number of deaths with the Omicron variant. As you guys have probably heard, the Omicron variant is presenting more like a cold or a mild flu. And so that's one of the good things about the Omicron variant, but it is very, very contagious. And if you look at just in the data overall, next slide, please. In terms of the number of deaths per the number of individuals who have been infected with the disease state, it would be a little less than 2% of deaths per a case or so. United States has been adversely affected the most by COVID-19, and then followed by India, Brazil, France, and the UK. And so this is something that we kind of have to consider in terms of, the patient population that we have versus others, and then taking into account the rules in terms of masking and social distancing and that type of thing. So in the United States so far, we've had about 71 million cases and about 886,000 deaths. And so that's something that we're going to have to keep in the back of our minds as we move forward with COVID-19. Next slide, please. Vaccinations in the US. If you go to the CDC website, they have a vaccine tracker that you can go to figure out based on age group, the percentage of people who have been vaccinated. And so if you look at the data for the number of people who have at least received one dose, if you look at the various age groups, so in total, right now in the United States, 5 years and older can be vaccinated. So of those who are eligible, 75.4% of individuals have at least one dose on hand. If you look at population greater than or equal to 5 years of age, it's 80.1%, which that looks kind of funny that one number looks different from the other. But population of greater than or equal to 12 years of age is 85.3%. Population of 18 and older is 87.3%, and 65 and older, which is the age group that we're focusing on, is 95%. So that's pretty good. If you move on to the next slide, it goes into those who are fully vaccinated. And so that number drops down quite a bit. We go to 67.3% for those greater than or equal to 5 years of age, 72.1% for greater than 12, 73.8% for greater than 18, and then greater than 65 is going to be 88.2%. And not everybody is getting on board with the booster doses so far. So if you go to the next slide, in total, they're saying it's about 39.5% of individuals who are eligible for the booster have received it. And so if you look at greater than 18 years of age, it's 42.6%, greater than 50 is 54.1%, and greater than 65 is 62.7%. I know there's been a lot of controversy with the booster doses in terms of, we are a first world country, and there are some countries that still have not received the original vaccine to begin with, such as third world countries. And is it valid for us to continue to boost ourselves when the rest of the world is not yet vaccinated? And so some people that I know of have been abstaining from the booster dose because they don't feel like they're at risk. Moving on to the next slide. So the booster eligible percentage is going to look similar. So about 53.2% of those who are booster eligible have been boosted. And if you look specifically at the 65 years and older, 36.5% have been vaccinated. And if you think about it, once you get one vaccine, your body has developed antibodies to the antigen. So most of these vaccines are mRNA based or protein based, and they all target the spike protein, which is on the COVID-19, correct? And so with this, so with the spike protein, the thing about the COVID-19 Omicron variant is that there's a lot of mutations in the spike protein itself. So that's something that we have to consider. But booster eligible, greater than or equal to 65 years of age. What I was trying to get with that was as you take more doses of the vaccine, you are going to see increased signs and symptoms or adverse effects from the vaccination because your body has already developed antibodies to the antigen of the spike protein. So if it comes into contact with another vaccine that contains antigens, you're going to react more each time that you get a vaccine. I don't know if any of you guys have noticed that, whether you've received the Pfizer product or the Moderna product or Johnson & Johnson. Moving on to the next slide. So if you look at the timeline for the Omicron variant, it started off in Botswana and South Africa, and the WHO, or the World Health Organization, was notified on November 24th. And then we started to see our first case in the United States in California on December 1st. And then by Christmas, it became the predominant variant in the United States. Next slide. So this is data in terms of the variant proportions shows the Delta variant here in that yellowish orange, and then Omicron in purple, which is also known as B.1.529. In a matter of 3 weeks or so, we started to see Omicron spread across the United States, and now it definitely is, 99.5% the majority of what we are seeing now. And that is a good and a bad thing for us. No, I think, so Kathleen had posted something in the chat about only 33%. I think of the people that are eligible, I think those are the ones that have been boosted, about 33% of the geriatric population, Kathleen. Next slide. So the Omicron variant has about 50 mutations in the virus, and since most of our vaccinations target the spike protein, it's quite a coincidence that there's 30 mutations in the spike protein with the Omicron variant. So that's why we are seeing even patients who have received the full course of 3 doses of the vaccinations, whether it's Pfizer, Moderna, or the 2 doses with Johnson & Johnson. In the future when that booster is there, the vaccine's not going to help in terms of preventing to get mild disease. What it is doing, and I've been seeing it in my own practice, is that it is preventing patients to getting to hospitalization and death. So that's what it's doing. So that's why even though we're still seeing mild infection and breakthrough infections in fully vaccinated individuals, it's still protecting us to getting hospitalized and possible death due to severe disease. If you look at how highly contagious the Omicron variant is, we talk about something called R0, which is basically for every 1 patient that is infected with Omicron, that person will infect 10 other people. So that's how contagious it is. And in a vaccinated situation, for instance, with measles, for instance, you would have maybe an R0 of about 7, and even they're saying with Delta it was an R0 of 7. But in a population with measles where people are unvaccinated, it could go up to 17. So this is actually highly contagious. And the thought is that you're only contagious for the first 2 to 5 days in most individuals, and that's why the CDC has changed their stance in terms of how long you need to self-isolate for on your own. But some individuals still may be contagious past that time point. I know some people think that this new 5 days is probably a political ploy in terms of getting the economy stimulated and not having to disrupt our normal daily lifestyle. But most people will stay contagious for about 2 to 5 days of infection. Next slide, please. So there is a difference between quarantining and isolating. So patients who are positive with COVID-19 should isolate, and those who have been exposed should quarantine if they've been in close contact with someone who has had COVID-19. What close contact generally means, and this is similar across a lot of institutions, is if you've been unmasked in the presence of a person who has tested positive for at least 15 minutes. And there's no social distancing that has occurred. So a lot of the website that I have here on this page is very, very detailed, and they have lots of graphics of if this, do this. And so if you do end up testing positive, or if you have a family member who is positive, a lot of what you're supposed to do depends on that patient's vaccination status and whether the patient is symptomatic or asymptomatic in terms of what they should do. Next slide. So CDC continues to recommend wearing a mask in public indoor settings in areas of substantial or high community transmission, regardless of vaccination status. So this was updated recently. And so if you can see here, the whole United States is basically red. So if indoors, based on the new CDC guidance, public indoor settings, high community transmission, everybody should be wearing a mask indoors and should follow the CDC guidance because of what's going on with Omicron right now. Next slide. So signs and symptoms of Omicron are very, very different from what we were seeing initially with the alpha, beta, and delta variants. So if you guys remember initially with alpha, beta, and delta, these patients were having may or may not have fevers, they were having coughing, they were having shortness of breath, they were losing taste and smell, and they were also having possible GI symptoms like diarrhea. With Omicron, it's more in line maybe with a cold, a mild flu, or allergies. So along the lines with allergies, we were seeing sore throats, runny noses, sneezing, headache, and fatigue. And in the past week, I've had 3 family members come down with Omicron, my nanny, my sister-in-law, and now my older daughter, and all of them started off very differently. My nanny, she started off with a sore throat. My sister-in-law started off with body aches, and my older daughter started off with runny nose. So I had taken my sister-in-law to see my Yes, I had taken my sister-in-law to see my PCP, and my PCP thought she initially had allergies and gave her some, told her to go buy some Allegra and some Flonase. And then they called us and said, oh no, the rapid is positive. And we're like, oh, so that's how similar a lot of this can look like. So if you move on to the next page, it goes into kind of a comparison of what Delta was like, Omicron, cold, and flu. And so if you look here, Delta, if you compare Delta versus Omicron, our Omicron patients are more fatigued for sure. And then aches and pains are going to be more common with Omicron, and sore throat's going to be more common, and as well as headache. Cold and flu, body aches can also be there with the flu. But when we go into allergies, next slide. The difference in terms of COVID-19 and seasonal allergies is, even now with COVID-19 Omicron, we are seeing sneezing, but you might also see itchy or watery eyes with seasonal allergies. And so this is a little bit of an older slide from August of 2020. When we were talking about more of the alpha picture. So there is a little bit of difference with Omicron. Omicron may look like seasonal allergies as well. So we do have to keep that at the back of our mind. If we already have seasonal allergies and we see a flare up, or we have a new cold, or if we have flu-like symptoms, it's best to get tested within that 2 to 5 day range of symptom onset, because that's the most likely time at which these tests will stay positive because of your contagiousness. Next slide, please. So unfortunately, the situation is that rapid antigen test kits are at a minimum. If you go to the local pharmacies or even try to buy them online, my local CVS, they have a sign up is, I'm sorry, we are out of rapid antigen home test kits. And there's also delays in PCRs. I know I've been to a drive-in site for rapids and PCRs, and I never get my PCR test back just because there's so many people who are testing right now. They do not have enough people and maybe reagent to be able to test in a timely manner and get the tests out. But luckily I was able to get my hands on some Binax now. But you guys might have heard this, the US government is allowing for us to order it through them. So that's something that we can do. You can get 4 test kits per 4 tests per a household. Next slide. So in terms of outpatient treatment options for Omicron, we are very limited. If you move on to the next slide, we have Paxlovid. And if you look at the data for Paxlovid, if I were to take an oral agent, this would be the oral agent I would want to take. This is nirmatrelvir or ritonavir, and it's approved for mild to moderate disease for 12 years of age and older who weigh at least 40 kilograms. And this is for those who are generally high risk to prevent them going into hospitalization or death. It has 89% effectiveness in preventing hospitalization and death. If you look at the data, the actual trials have not been published yet, but it was studied in healthy unvaccinated individuals. But I know sites that are allowing for unvaccinated individuals, vaccinated individuals to still get Paxlovid. The problem with this is you need to take this within 5 days of symptom onset. And also it is very, very expensive. So it's $700 per treatment course if you're able to get it. And so hopefully your insurance company will cover it. But this was approved on the emergency use authorization by the FDA right before Christmas on December 22nd. Next slide. So the next day after that, molnupiravir, which is also an oral agent that was approved for mild to moderate COVID-19 use on the outpatient setting, this was also approved. Unfortunately, the numbers don't look as great as Paxlovid. So if I were to choose out of the two, I would definitely recommend Paxlovid over molnupiravir, since this is only 50% effective in preventing hospitalization or death. If you're interested in looking at the data, the phase 2 and phase 3 data, the study is called Move Out study. There was a lot of controversy with molnupiravir because it is contraindicated in pregnancy. So I would not recommend this in childbearing potential males and females. And again, like Paxlovid, it does have to be taken within the first 5 days of symptom onset. And again, this is, I couldn't find exact data, but it's thought to cost about $700 for the whole course. Next slide. Not all monoclonal antibodies for COVID-19 are going to work for Omicron. Actually, the only one that will is sotrivimab. And so that's where we run into a problem, because now we are on a shortage with sotrivimab. Next slide, please. The Evishield or the tixagevimab combination, that one was the one that was approved recently. That one is approved for pre-exposure prophylaxis of COVID-19, but that has no activity against Omicron. So that puts us in a pickle there. But sotrivimab was approved in May 2021 as a monoclonal antibody. And this is the only one, again, that is active against Omicron, but it is on back order because not a lot of people are able to get it. In order to receive it, it's for outpatient use only. So if you are to receive the IV product, you're going to have to go to an infusion center or like an outpatient clinic to receive the infusion, or the emergency room department, and the patient shouldn't be receiving oxygen. And this, for the whole treatment course, it's going to be about $2,500 without insurance. And then compared to the oral agents, you need to take this product within 10 days of symptom onset. So there is some leeway here. And I have seen, even though sotrivimab was studied in healthy unvaccinated individuals, I have seen some institutions lean away from that and give it to vaccinated individuals because of the dire situation that we're in right now. Next slide. Remdesivir outpatient times 3 days. So remdesivir was the very first antiviral medication that was approved by the FDA specifically for COVID-19. A study came out right before Christmas called the Pine Tree study that looked at giving remdesivir in the outpatient setting for COVID-19. And they found that it was about 87% effective in terms of lowering the risk of hospitalization or death compared to placebo. But if you were to give me an option, I feel I would take Paxlovid over an IV product just because of ease of use. Similar to sotrivimab, because it is an IV product, it is going to be about $2,500 per treatment course for the patient. Next slide. So in conclusion, really, the mainstays in combating the mainstays in combating the Omicron variant haven't really changed. Vaccines are still recommended, even though they target the spike protein, and there are modifications in the spike protein with the Omicron variant. It still prevents hospitalization and death. Masking indoors is still preferred. And still recommended because all of the United States is high risk right now. Social distancing is still recommended, and of course, hand washing. So nothing has really changed here. We're kind of, I feel like, at ground zero again, back at alpha and alpha, beta, So we kind of have to go back into that. And what I've heard from the ID physician that I work with is that if one family member gets it, it's very likely that all of the family members will get it unless you use appropriate isolation techniques in terms of isolating that person in a room and bringing them food and water and that types of things. So it is a very difficult situation right now. And I know a lot of families are having a difficult time, including myself.